So good afternoon, friends. It is midnight here, and as you can imagine, I'm fully alert and enjoying talking to you. And I'm going to talk to you about my favorite subject, a subject which has fascinated me for the last 35 years. And I'm happy to talk to people who have been fascinated from this subject for a long time and are international experts. I'm going to talk to you about Chiari Malformations and Syringomyelia. And I'm going to try to analyze the relationship of both of these problems with Atlantoaxial instability. As you have heard for the last 2 days, these are not simple issues. These are quite philosophical and difficult to understand problems. And the final word is not yet said. Chiari malformation and Syringomyelia are a common combination of clinical and radiological event. Chiari malformation is frequently associated with, not very frequently, but sometimes associated with Syringomyelia and Syringomyelia. Basilar invagination, Chiari malformation, and Syringomyelia is a common and frequently identified triad. On several occasions, with Chiari malformation, there is manifest Atlantoaxial instability. So the issues are quite clear in such a situation. Chiari malformation may be associated with no bone abnormalities of the craniovertebral junction. So my question is, Chiari malformation, Syringomyelia, when it is not associated with any craniovertebral bone abnormality, is it different when it is associated with craniovertebral anomalies like basilar invagination and Atlantoaxial instability? My answer to that question is Chiari malformation 1 and Syringomyelia, whether it is associated with basilar invagination or not, whether there are any craniovertebral bone anomalies or not, this complex is always associated, and take my word, always associated with Atlantoaxial instability. So this is the concept which I am going to put forth to you, and I would like to hear your opinion on this concept. As you all know, and you have been discussing for the last 2 days, Chiari malformation has been described for over a century, but nobody knows what is Chiari malformation and why there is tonsillar herniation. And because nobody knows why this happens, there are a number of treatment protocols that have been discussed for this entity. Craniectomies of posterior fossa decompression, C1 laminectomy, C2 laminectomy, tonsillar resection, opening of the dura, dural graft, dural patches, reconstruction with metal implants, and so on and so forth. In my article, which I had written on this subject, I had written the number of treatment protocols for Chiari malformation is equal to the number of surgeons performing this operation. The most beautiful and important issue is that every surgeon thinks that whatever he is doing is the best and is the most rational or philosophical form of treatment. In the year 2014, I had written an article in Journal of Neurosurgery where I mentioned, is Atlantoaxial instability the cause of Chiari malformation? So this is a very important and probably a revolutionary statement in this subject. Is Atlantoaxial dislocation the cause of Chiari malformation? Essentially meaning thereby that is the treatment of Chiari malformation Atlantoaxial stabilization? Is Chiari malformation a primary event or is it a secondary event secondary to Atlantoaxial instability? Is Chiari a formation or is it a malformation? Is it good for the patient or is it bad for the patient? Is it pathological or is it a divine intervention to save the human being from Chiari malformation and the symptoms related to this problem? Is it primary or is it secondary? The other very important and also probably a revolutionary statement which I am making in front of you is an introduction of a new kind of classification of Atlantoaxial instability. This classification, I have labeled it as a central or axial instability. And believe me, my friends, if one understands this new concept or new form of Atlantoaxial instability, there is a possibility of revolutionizing the treatment of not only Chiari malformation, but also a lot of other abnormalities of the cervical spine, including degenerative spinal issues and cervical spondylosis and OPLL and things like that. So I'm going to introduce to you a concept of central or axial Atlantoaxial instability. To come to these concepts, I would like to give you my own personal historical perspective on this treatment of craniovertebral junction and related issues. Craniovertebral junction instability, fact about facets. This article I had written in Asian Spine Journal recently. Atlantoaxial joint is the most mobile joint of the body. On the other hand, occipital atlantal joint is the most stable joint of the body. It may not be wrong to say that all craniovertebral junction instability is equal to Atlantoaxial instability. Occipital atlantal instability is extremely rare, and it is identified in some cases of severe trauma and some children with syndromal issues. In general, my concept is craniovertebral junction stabilization is equal to Atlantoaxial stabilization. We have introduced this technique of introduction of one screw in the facet of atlas and one screw in the facet of axis, opening of the joint and introduction of bone graft into the joint in the year 1988. So approximately 30 years ago, we had introduced this technique. And those who are in it know that this technique is now a very prominent technique of Atlantoaxial fixation. We have also introduced for the first time in the literature, amongst the first time, use of screws in the occipital bone and incorporation of C1 facetal fixation and C2 facetal fixation in occipitocervical fixation. But today I am saying, occipitocervical fixation, is it necessary? I am saying, and I'm absolutely convinced, that inclusion of the occipital bone in craniocervical instability-related issues is not a good form of fixation. I consider it as a negative operation, and I am having no doubt that inclusion of occipital bone reduces the quality of atlantoaxial fixation, and it should be completely abandoned. For the last several years, I do not include the occipital bone in my fixation construct. Basilar invagination, I am going to talk to you a lot, but that does not mean that Chiari malformation with basilar invagination and without basilar invagination are different. In the year 1998, I had described 190 cases of basilar invagination, so about 20 years ago, where we have discussed two types of basilar invagination. One is when the odontoid process goes inside the foramen magnum and there is no Chiari malformation. And the second is when there is a Chiari malformation. So in the year 1998, we had said that these are two different types of basilar invagination, but the commonality of both these basilar invagination was, and very crucially important at that time, that these were considered to be fixed or irreducible atlantoaxial dislocations. These were not mobile. These were not considered mobile at that time in 1998. And the treatment accordingly was transoral decompression in this situation and foramen magnum decompression in this situation. This was the treatment. In situations with basilar invagination, small osteofossa and Chiari malformation and its clinical implications were discussed by us in this paper for the first time in the literature, and we mentioned that for the treatment of Chiari malformation and foramen magnum decompression in situations of basilar invagination, bone decompression is not necessary. Even in the presence of Syringomyelia, bone decompression is not necessary. So this was my concept in 1998. In the year 2004, we introduced an absolutely radical change in the understanding of craniovertebral junction in general and basilar invagination in particular. We introduced the concept that manual manipulation, handling of the facets, handling or manual manipulation of the facets and distraction of the facets of the atlantoaxial joint can reduce basilar invagination. And with this paper, I'm sure and I'm convinced that this article of mine completely relegated transoral surgery into realm of history. Today, I say if you do transoral surgery for odontoid process decompression, you do not understand craniovertebral junction. The role of craniovertebral junction realignment was introduced in our article in 2004. And this was published as a cover page of Journal of Neurosurgery. So this kind of case where transoral surgery was a mandate, and I was personally doing a number of these cases, opening of the joint, distraction of the facets, can reduce basilar invagination without any bone decompression from the front. Craniovertebral junction realignment came into picture. So when there was basilar invagination like this, we introduced the concept that it is not fixed, it is mobile. It is not only mobile, it is pathologically and hypermobile, and such patients need craniovertebral junction realignment by facetal distraction technique, which we introduced. So my concept was that basilar invagination, this is C1 and C2 with C1 assimilation, is equal to lumbosacral listhesis, and lumbosacral listhesis is a problem of instability. Similarly, basilar invagination is an issue of C1, C2 listhesis and is a problem of instability. So instability was the issue and stabilization was the solution. However, and here in a similar situation, basilar invagination, listhesis is the problem, craniovertebral realignment. You see here there is basilar invagination and transoval surgery would have been done otherwise, but craniovertebral junction realignment is a possibility. Listhesis of C1 over C2 is the problem and realignment is the solution. So we introduced in 2005 that a select group of Chiari malformation and Syringomyelia, where there is this kind of basilar invagination, you can reduce the basilar invagination. However, in my classification, even in 2004, when the odontoid process was not invaginating inside, in this kind of situation, my concept was foramen magnum decompression should be done. In 2004, I described this. That decompression for this group of basilar invagination is a good option when there is Syringomyelia and Chiari malformation decompression. And I did a number of these operations. However, as we progressed and as we matured and as we understood this subject more intensely and deeply, we realized that basilar invagination is always associated with instability, and all kinds of basilar invagination need stabilization of the atlantoaxial joint. Whether the odontoid process has migrated in the foramen magnum or not, atlantoaxial, not occipitoaxial, atlantoaxial fixation is the treatment. When there is tumor and there is Chiari malformation, obviously we have to remove the tumor. So when there is Chiari malformation, we have to try to find out why there is Chiari malformation. And my answer to this question is, Chiari malformation is always a secondary issue. Similarly, we introduced long time ago this concept that Syringomyelia is not a pathology. Syringomyelia is helpful for the human being. It is not harmful. Syringomyelia is a natural protective phenomenon. It is secondary phenomena to atlantoaxial instability. So this was my concept in 1995 or 1996, this article I have written. In the presence of craniovertebral junction abnormalities, all craniovertebral junction problems are related to one primary issue, and that is atlantoaxial instability. So the word craniovertebral anomaly, I have removed this word anomaly because it is not an anomaly, it is a protective device of nature. Short neck, torticollis, platyvapia, clipple file abnormalities, bone fusions, assimilation of atlas, C2-3 bone fusion are musculoskeletal changes in basilar invagination, which are all secondary to atlantoaxial instability. The issue is if you stabilize the atlantoaxial joint, all these musculoskeletal abnormalities can reverse. Not only reverse, but they will reverse in the immediate postoperative period in the evening of operation to an extent, and then it will improve. So the musculoskeletal abnormalities of various kinds are not embryological phenomena or embryological dysgenesis or a problem of embryogenesis, but it is a divine intervention. It is a miracle of God. It is a protective phenomenon in the event of atlantoaxial instability. So there is basal invagination, and there is atlantoaxial fixation, and there is a reduction in the torticollis in the immediate postoperative period in the evening of operation. And if you realize, the neck has also become long and very soon after operation. You must have heard, and we all have heard, that bone fusions are due to problems of embryogenesis. Spina bifida is a problem of embryogenesis, but this spina bifida is not like lumbar spina bifida. This is a nature's protective phenomenon. Bone fusions are not primary problems. Bone fusions are secondary to atlantoaxial, chronic atlantoaxial instability, and are nature's design to reduce the neck size to have a comfortable course for the spinal cord. Bifid anterior and posterior arches of atlas are natural designs, and they open and close, open, close, open, close on flexion and extension of the neck. When there is flexion, it opens. When there is extension, it closes. So open door kind of phenomenon, which is a nature's protective laminectomy or protective decompression. So bifid anterior and bifid posterior. Bifid posterior is almost always associated with bifid anterior, and this is a mobile. It moves with flexion and extension and opens and closes. So these are primarily protective phenomena. Now I come to the issue of an alternative definition, alternative classification of atlantoaxial instability by monitoring the facetal alignment. Atlantodental interval disturbance. You see this atlantodental interval disturbance, you do flexion, you do extension, and when there is atlantodental interval disturbance, you call it instability. So this parameter of atlantodental interval disturbance or indentation of the odontoid process into the spinal cord is the only parameter for last several decades which has been used to monitor atlantoaxial instability. We introduced this facetal listhesis as one of the parameters to monitor atlantoaxial instability. So there is atlantodental interval disturbance here, and there is facetal malalignment here. Atlantodental interval disturbance here. When there is instability, there is a need for stabilization. When there is Chiari malformation, there can be reverse. You see this slide, the facet of atlas is behind facet of axis. So just see this slide, the facet of atlas is in front of facet of axis. Facet of atlas is behind facet of axis. So this kind of facetal instability can be present even in the absence of atlantodental interval disturbance. And the need is stabilization. There can be severe basilar invagination. There is no atlantodental interval on dynamic imaging. but there is facetal malalignment of a reverse kind. The facet of atlas is behind facet of axis. So this kind of facetal malalignment, I call facet type B kind of malalignment, there is no atlantodental interval disturbance. You see, there is Chiari malformation, there is no atlantodental interval disturbance, there is facetal malalignment, facet of atlas is behind facet of axis. So when you have to analyze the atlantoaxial instability, you have to look at the facets, and they suggest no decompression. It will be highly dangerous for this patient. It is an unstable phenomenon and it needs stabilization. I introduce another very radical concept, that presence of Chiari malformation, presence of basilar invagination, even in the absence of atlantodental interval disturbance, even in the presence of normal facetal alignment, it is an unstable joint meriting the need for atlantoaxial stabilization. So this concept that this Chiari malformation is in itself an indicator of atlantoaxial instability is an absolute radical concept in this subject. Basilar invagination, no problem with atlantodental interval, no problem with facetal alignment. Chiari malformation, basilar invagination, the need for atlantoaxial fixation. The other thing which I did not mention in my slides, if you had monitored my slides, there is no tight posterior fossa. You see, there are huge subarachnoid spaces here. Fourth ventricle is normal. There is no question of need for foramen magnum decompression, which today I say that foramen magnum decompression of all kinds from behind or front is a redundant or a negative or a counter-effective operation. Radical statement to make, but this is what I have to tell you. Chiari malformation, Syringomyelia, no atlantodental interval, no facetal malalignment is an unstable phenomena, unstable situation, no question of tight posterior cranial fossa. Basilar invagination, you see no tight posterior fossa, Syringomyelia. You see the facetal malalignment type B and the need for atlantoaxial stabilization. There is no need for foramen magnum decompression. There is no need for inclusion of the occipital bone in the fixation, even in the presence of assimilation of atlas, even in the presence of any kind of bone abnormality of the region. Chiari malformation, no tight posterior cranial fossa, facetal alignment and fixation. Chiari malformation, no tight cranial fossa, you see big syringomyelia and only atlantoaxial fixation you see in the immediate postoperative. After 24 hours of operation, the size of syringe has reduced and delayed it has reduced further. I am not saying, and I cannot say today that Syringomyelia will reduce in all the patients. I cannot say today that the tonsil will go up in all the patients, but I can say with 100% conviction and with great confidence that the patient will improve in his clinical symptoms in the immediate postoperative period, no question about it. No tight posterior fossa, foramen magnum decompression is not a good operation. Not a good operation of any kind, no dural compression, no tonsillar resection, nothing. What is required to be understood is it is an unstable phenomenon in the presence or in the absence of facetal malalignment, and the need of the situation is atlantoaxial fixation, and you see the syringe has reduced in this situation and the posterior fossa is absolutely comfortable. More than anything else, remarkable clinical improvement of the patient. Big syringomyelia, Chiari malformation, no atlantoaxial instability, fascicle instability, and atlantoaxial fixation, and reduction of the size of syrinx, and elevation or superior rostral migration of the tonsil. I am again saying that syrinx may not reduce in all the patients. I do not have an extremely long follow-up, but I can say that the patient recovers in all the symptoms, including dysesthesia, pain, tingling, numbness, and all kinds of breathing issues, and quadriparesis, and all kinds of things. Syringomyelia, Chiari malformation, tonsillar herniation, and postoperative imaging with atlantoaxial fixation, see the fascicle malalignment. This kind of situation, no way you will do a foramen magnum decompression. It will increase the atlantoaxial instability. It can harm the patient. It can certainly have a negative influence on the treatment of these patients. Syringomyelia, fascicle malalignment may be big, may not be big, may not be present, but it is an indicator of atlantoaxial instability, suggesting atlantoaxial stabilization, and you see the posterior reduction of the syrinx volume. Little bagler invagination, no fascicle malalignment, Chiari malformation, syringomyelia, atlantoaxial fixation, reduction in the size of syrinx. Another patient where there is a manifest problem of atlantoaxial joint facets are in a very abnormal condition. Syringomyelia, Chiari malformation, you do atlantoaxial fixation, you see the result, the Chiari malformation and syrinx has reduced remarkably. So the answer to the question of Chiari malformation is, in my understanding, that Chiari malformation is due to atlantoaxial instability and atlantoaxial stabilization is the solution. Atlantoaxial instability is the cause and atlantoaxial stabilization is the treatment. Syringomyelia and Chiari malformation are both nature's protective formations to stall or delay the effects of atlantoaxial instability. Chiari malformation is like nature's protective airbag here. When Chiari malformation is present, it is diagnostic. Chiari malformation is diagnostic of atlantoaxial instability. In situations where there is idiopathic, today I heard a lecture by somebody on idiopathic syringomyelia. Means there is no bagler invagination, there is no atlantoaxial instability, but there is syringomyelia, there is not even Chiari malformation, but there is fascicle malalignment, central or axial atlantoaxial instability, and you treat by atlantoaxial fixation, you find remarkable clinical recovery. That is the bottom line of our treatment. No matter whether syrinx reduces or Chiari resolves, but you see, there is no bagler invagination, there is no Chiari malformation, there is atlantoaxial instability, and there is treatment by atlantoaxial fixation. Syringomyelia, bagler invagination, fascicle instability, reduction in the size of syrinx, and atlantoaxial fixation. Foramen magnum decompression was done somewhere else. Syringostomy was done again. But the syrinx persisted, Chiari persisted, either atlantoaxial fixation, syrinx gone, atlantoaxial, and remarkable, believe me my friends, remarkable improvement in clinical situation. So the treatment of Chiari malformation and syringomyelia is atlantoaxial stabilization, occipital fixation is not necessary, and foramen magnum decompression is a counter-effective operation. Today I say, can foramen magnum decompression become historical? I say yes, can become historical. Short neck, torticollis, and all these musculoskeletal abnormalities are external manifestations of atlantoaxial instability. Syringomyelia and Chiari malformation are neural manifestations. I will take about 2 minutes more. I want to introduce to my dear friends and very knowledgeable friends on Chiari Malformation and Syringomyelia a new concept of Syringomyelia. External Syringomyelia. You see, this is internal syrinx, this is external syrinx. This is internal syringobulbia, this CSF is external syringobulbia. The presence of external syrinx and internal syrinx and internal syringobulbia and external syringobulbia are determined by the angulation of the odontoid process. A beautiful new concept. External Syringomyelia. External Syringomyelia, this is a brand new term and which can also have a very revolutionary impact on the treatment. And these are the parameters which I have designed on various, and the angulation of the odontoid process in anterior-posterior perspective, in horizontal and transverse perspective, determine the presence of internal syrinx, external syrinx, internal syringobulbia and external syringobulbia, this angulation. So when the angle is normal, when the odontoid process is down, then there is no external syrinx but internal syrinx and Chiari malformation. Chiari malformation, when the odontoid process is straight up, there is Chiari malformation and Syringomyelia. When it is oblique, there is external Syringomyelia. Treatment is Atlantoaxial stabilization. Internal syrinx, external syrinx. Internal syrinx, external syrinx, Chiari malformation, facetal malalignment. Whether there is bone abnormality or not, whether the odontoid process is angulated or not, whether there is babular invagination or not. This is an unstable atlantoaxial joint and it needs atlantoaxial stabilization. Atlantoaxial stabilization is the treatment. Central or axial atlantoaxial instability can expand the scope of treatment. Nature's design, the nature comes in picture. Atlantoaxial instability, the nature's reparative game comes in picture, and we should understand the beauty of nature and beauty of God who made our body and who is there to protect in case of problems in general, and Chiari malformation and Syringomyelia in particular. Thank you very much. Could you hear me? Yeah, the question is, my view about Chiari malformation 1 is a little bit atypical. What about cases in which there are no craniovertebral abnormality but only a small posterior cranial fossa? See, when I talk about Chiari malformation, this issue of small posterior cranial fossa I have discussed, and my recent new paper is coming on posterior fossa small and small neck and short head and things like this. Small posterior cranial fossa is also a manifestation of atlantoaxial instability, Chiari malformation. So whether there is bone abnormality or no bone abnormality, see, I'm not talking of cases like craniostenosis, I'm not talking of cases where there is hydrocephalus, I'm not talking of cases where there is spina bifida and things like that, but I'm talking of Chiari 1 malformation, where the patient presents with symptoms of dysphagia in the hands and paresthesia in the limbs. These kind of patients are a manifestation of atlantoaxial instability. So do you have any other question for me? Whilst you are preparing your questions, I will give you some more issues on this. One, and the bottom line is, Chiari malformation in the presence or in the absence of bone abnormality of Atlantoaxial region and craniovertebral junction, like bone fusions, bilateral invaginations, and things like that, is a manifestation of Atlantoaxial instability. Now, whether there will be Syringomyelia inside the cord or presence of CSF outside the cord, or whether there will be Chiari malformation, will be determined by the angulation of the odontoid process. Now, the next question that has come is, do you see any connective tissue disorder in your cases? I heard a presentation of Ehlers-Danlos disease today, or multi-level, multi-syndromal issues like even Morque's disease and Down syndrome, where there are multi-joint issues. In these cases, of course, Atlantoaxial joint and other joints can also be in question. I do not see these things very often, but these are also indicators that instability is there in the Atlantoaxial joint, and when this is associated with Chiari malformation, it merits the need of Atlantoaxial stabilization. So that is the answer to this question. The issue of, whilst you are preparing your next question, I also want to talk to you about central instability and central facetal instability. Is not only an issue with Chiari malformation, but it can also be an issue with cervical degeneration, and if those who are interested must read my new papers. In any case, I have been told that my time is over, and I thank you, my dear friends, and I hope I can contribute to this subject of our great interest, and I thank Paolo for inviting me amongst all of you very learned people. Thank you very much.